Very good, very good. And welcome. We
Hi.
are live.
Hi.
Thank you for joining us, everybody. This is Dr. Sarah Merritt with Lifestream Health Center, here with Dr. Dana Gibbs, a friend and colleague who is starting a practice called Consultants in Metabolism. Uh, Again, at Lifestream Health Center, I'm Dr. Merritt. I'm board certified in anesthesiology, pain management, and also addiction medicine. We're working to make pain care more caring, accessible, patient-centric, and evidence-based. And so we want to see you if you're in Central Maryland. Please come visit us. All right, and so I've got today Dr. Dana Gibbs, who is a physician also. Welcome, Dana.
Hi there. It's so exciting to be here with you.
Thanks for being here. Tell us a little about yourself, Dr. Gibbs. I know that you have trained in ENT and you've worked as an ENT doctor, but you've also developed expertise in thyroids and endocrine through
Yes.
your career as an ENT. Is that right?
Yes. So, yeah, it's a little bit interesting how I ended up with that because people are like, "You're an ENT. What does that have to do with pain management and endocrine?" And actually, a little bit, but a lot of my story is my personal story
Mm-hmm.
of going through thyroid dysfunction and burnout, and then realizing that that's actually a physical problem that you can do something about. And that's a big part of what pushed me to start an endocrine practice, like an integrative endocrine practice, as I came close to my retirement from ENT and decided, hey, you know what? I still have a lot to offer. I want to do this. So here I am.
This is exciting, yeah. And so you've seen improvements in your own health with better treatment of underlying conditions,
Sure,
thyroid
absolutely.
conditions in particular. Yeah, tell me more about that. I mean, I think that's such a what do I want to say? Like, I don't know if I want to say like hot button issue, but that's such a it's not just like totally straightforward, right? Like, oh, you have X, so do Y. I mean, it sounds like
Right.
maybe some differences of opinion and what
Sure.
constitutes a thyroid problem and how would you measure it and how would you follow it. And there are different
Exactly.
doctors that would approach these same lab values or same symptoms differently.
Right. So when I was in med school, and oh my gosh, it's 30 years ago now. Oh my goodness, it's hard to think, hard to believe. You know, thyroid was normal unless your TSH was elevated,
Yes.
and unless you were overweight, and that's just how it was. After the invention of Synthroid. Now, before the invention of Synthroid back in the 1970s, apparently things were really different, and people actually paid a lot of attention to symptoms and that sort of thing. Um, and there just happened to still be some old timers out there who know some of that stuff.
Mm-hmm.
Um, but what happened with me is as I went through medical school and residency, I just got tireder and tireder and more depressed and had more and more trouble keeping up.
Mm-hmm.
And, I had some other kind of weird symptoms. I was cold all the time. I was
Yeah.
constipated. I was, my hair was falling out. I had basically no hair up here on top of my head. And I would go in and they would check my TSH and they would say, oh, everything is fine. Um, and so I just thought, oh, well, I just must be lazy. I'm a lazy person. That's, I'm just, not a good resident, blah, blah.
Yeah.
But anyways,
Able to do this.
I managed to get through residency and get out into private practice and set up a private practice doing ENT, which is not so far off because ENTs do thyroid surgery.
Right.
So,
Yeah. Patients with
so
thyroid abnormalities
there
routinely.
is, so there is routinely thyroid patients sent through my office.
Mm-hmm.
And not all of them needed surgery. Some of them needed to be treated medically. And
Mm-hmm.
so when I figured out my own problems, and I didn't really figure them out. So here's what happened. It was funny. I went to an allergy conference, and it was the same allergy conference with the same talks they'd given the year before. And so I was like, yeah, I'm a little bored. I'm going to go into the other room next door and listen to this guy talk about hormones. And I sat there and my jaw just basically hit the floor because every symptom he was saying was me. And I'm like, oh my goodness. This is, 20 years of being told, oh, nothing's wrong, nothing's wrong.
Right.
So, and he didn't really have the answers as to why or what was going on. He just said, some thyroid patients have normal TSH, and if you give them this medicine, they will feel better.
Mm-hmm.
And luckily for me, that's exactly what happened. I went back home. I went to my GYN, who was my primary at the time, and I said, can I please try this? And she was gracious enough to write me the prescription. And it was like this miracle. It's like, oh, wow, is this what normal people feel like?
Oh my gosh.
Because I just thought that being tired and wanting a nap every Saturday and, being ready for bed the minute I got home was normal. I thought that was the way things were.
Right.
And it wasn't. And it was very, very different. And being the inquisitive person that I was,
Mm-hmm.
I did not settle for, we don't know why. I didn't settle for that.
Yeah.
And eventually I found another professor who lectured on something called reverse T3. And he said, if you measure this and you measure that and you compare it to the reverse T3, then you can figure out the right dosing for somebody so that they're not getting too much and they're not getting not enough, which is actually pretty easy to do in thyroid treatment. And so I gradually started noticing as I went through, I would start offering this treatment to patients who didn't need thyroid surgery, but they had something wrong, and watch them get better. And then I started recognizing those symptoms in people who weren't even there for thyroid. They were there for, I'm sick all the time. I have sinus all the time. And I'd say, hey, can we check your thyroid numbers? And I had this one situation that really hit it home for me, which was a lady who I thought needed sinus surgery. I mean, her CT was terrible. Her symptoms were terrible. She came in and I said, and she was like, well, I'm a school teacher. I can't do the surgery right now. And I said, but here's this thyroid medicine. And then she didn't come back for like 6 months. And I'm like, what's up? And she finally shows back up. And I'm like, when are we going to do your sinus surgery? And she's like, oh, I don't need that anymore. I'm all better. I just need more of that thyroid medicine. And I was like, whoa. There's really, and apparently it really does. It really kind of damages your immune system to not have sufficient thyroid going on. But as I have learned more and more and gone back to this integrative endocrinology approach, what I've discovered is that there's a lot more to it. It's all wrapped up in all the other hormones. It's all wrapped up in your cortisol, your stress hormones, your pituitary, your sex hormones, all the things. And, when I look back on how I was, in med school where I couldn't get through rounds without feeling like I was going to pass out, that's because my adrenals were shot, basically. So
yeah, we hear some talk about adrenal fatigue. Is that analogous to this thing?
Yeah, exactly.
Analogous.
Yeah, there's a lot of, okay, so for people who don't know, mainstream medicine takes about 20 years to assimilate any new concept that comes in. So for example, and I'll just use x-rays as an example, back in the 1950s when x-rays were new and people were putting their feet in x-ray machines in the shoe store just because it was cool to see the bones of your feet.
Yeah.
They had no idea, but then one day somebody says, oh my goodness, x-rays cause birth defects. And it took 20 years before the recommendation to avoid x-rays in pregnant ladies and to cover their abdomens if they were pregnant during an x-ray and to check to see if somebody's pregnant before doing a CT scan of their abdomen.
Yeah.
It took 20 years. Once that data was known and proven that X-rays cause birth defects for it to take effect. So this is kind of the same thing. It's starting to be more accepted.
Mm-hmm.
But as long as there's not a fabulous test that tells us exactly what your adrenal status is, it's still going to be that the majority of physicians are going to say, oh, adrenal fatigue, that doesn't exist. But there's actually, if you look at it from an indirect approach and you look at the kind of conditions that are associated with low peripheral body cortisol and things like that, you start to, the preponderance of evidence is there. It may not be a double-blinded placebo-controlled trial that says if you give X amount of cortisol, you can cure this and this and this.
Mm-hmm.
But the truth of the matter is there's ways to treat it. And I do think it's real. And I'm pretty convinced that it's real.
Well, and there's a lot of decisions in medicine that are risk versus benefit, right? And so then what's the risk of treating a hormonal problem? And hopefully it's in the treatments that you might actually give, hopefully it's low. And I think that's
actually very low, because your body has ways of self-regulating.
Mm-hmm.
The certain supplements that I now recommend to people, your body has ways to self-regulate. Mm-hmm. The ones where we can't measure well. And now that I know how to measure well on the thyroid, I can get people perfectly balanced right in the middle. And they, you can tell if you're too high, you have symptoms. If you're too low, you have symptoms. If you're right in the middle, you feel pretty darn good. So, so anyway, I was doing a little bit of looking things up just so I wouldn't misspeak as we talked, but there is so much evidence about adrenal fatigue and chronic pain. I was just blown away by how much there is. And
tell me more, because I really probably need to learn this too, in terms of being,
this when I was looking at this data and I was just kind of blown away, because what happens when you have, and it's almost a which came first, the chicken or the egg, because the chronic stress increases the pain, which increases the stress. So it becomes this vicious cycle that just gets, if it's left unchecked, it just gets more and more and more and more. And so some diagnoses that are associated with this chronic fatigue are, you've heard of chronic fatigue syndrome.
Yes.
Of course. You've heard of fibromyalgia.
Mm-hmm.
You've heard of burnout. You've heard of PTSD.
Sure.
You've heard of overtrained athlete syndrome, I'm sure.
Sure. Yeah.
And then the other things that happen is that you get into more chronic lung disease, more chronic allergy disease, anemia, insomnia, low libido, anxiety, and they just all feed on each other, and it just becomes more and more and more. So
for sure, we see patients, and sometimes we'll even lump some of those things into mood, right? Like, low libido. Well, what's mood? What's, a hormonal related thing? And I think sometimes it's hard to know, but if we can at least, I think it's really exciting if we have an opportunity to treat, hey, are there hormonal factors that could play into, some of how we feel, and then thereby improve how we feel, whether that's, mood or general, and then thereby improve, our outcomes.
Yeah. So maybe I'll just step back a second and we can talk about what happens when you get under stress. So, and it changes from acute stress, like, oh, I was nearly in a car accident this afternoon, to chronic stress. Man, I hurt my back and it keeps me awake every single night. There's some changes, but overall it's just a magnification and a continuation of the same changes. Mm-hmm. So when you injure yourself or when you get under stress, the first thing that happens is that your body releases adrenaline. The very first thing that happens. I mean, that happens in 1 second. Boom, adrenaline. You know, and then
and you feel
by the time
in that acute
moment. Your heart goes fast. You feel, you know, super, you know, like your skin's on fire almost, you know, just like hyper aware, hyper alert. Get shaky. You're, you know, feeling like your blood sugar drops. And the reason it feels like that is because that's actually what happens. But then cortisol kicks in, and cortisol takes about, I don't know, 30 seconds to start kicking in. You know, and the reason you'd need adrenaline and cortisol is because, you know, when the lion jumps out of the bushes at you, you can't wait 30 seconds to react. You have to, you know, you have to be ready to jump. But then he's chasing you, so you have to be able to run a long way. And so you need both of those things to manage this acutely stressful event or whatever that happens. And that's actually helpful. That helps you survive. But when it's not a lion, when it's actually more that your boss yelled at you, or you're in a work environment where it's horrible all the time, or, you know, you've got a bad home environment, or you can't pay your bills, or, you know, there's all kinds of reasons why, you know, because humans are the only species who can create our own stress in our bodies, create the same physical stress reaction by worrying about things. We're the only species that can do that.
Internal experience.
Exactly. The internal experience of whatever's going on. But anyway, so the things that start happening is, first of all, you get decreased insulin sensitivity. And when you decrease insulin sensitivity, that's so that your blood sugar will rise and go to your muscles, which don't need insulin, so that you can run away. That's why that happens. But if you're not actually running away, then your blood sugar goes up, and then your insulin goes up, and then your insulin stays up. And insulin has all kinds of effects that, when they're prolonged, they are not good for your body. And we can go into those more if you want to. Some other stuff that happens with that acute stress response is some changes in neurotrophins and neuropeptides that create what's called neurogenic inflammation, which is basically in your brain. And then it changes your thyroid. It's like the higher your cortisol gets, the lower your TSH gets. So it's like after a little while, the elevated cortisol and the ACTH part, all this HPA axis, the brain to the pituitary gland to the adrenals to the other hormones, it starts pushing down on thyroid and saying, we need to rest, we need to back off, we're going to starve to death,
so
we need to
conserve
the thyroid. We need to conserve energy, so it drops your thyroid. It also causes hypervigilance, because there's so much extra epinephrine, norepinephrine being released in your system. So you get this extra vigilance thing. And then your body starts conserving resources. So it pushes down on growth hormone, it pushes down on FSH and LH, so that your sex hormones start getting dysregulated. And because your body is fighting for survival, you don't need to reproduce, you just need to survive. So that's when you get into all these conditions that are just so negative. You also get into this immune system changes towards allergy and autoimmune disease, because your body is trying to fight the inflammation that happened from possibly an acute injury that happened. You know, it's like this is a blunt hammer that your body has to try to take care of this. It doesn't understand the difference between a diet where you're restricting your calories and physically starving to death. You know, it doesn't understand you're doing it to yourself because you want to lose weight.
You would like to lose weight, but the body says no thanks. Anyway,
so when stress gets chronic, it starts pushing you towards allergy and towards autoimmune disease, which as we know, that a lot of the autoimmune diseases are very, very tied up in pain syndromes because it's arthritis and things like that. But it just goes on because insulin does other negative things. It stimulates anxiety. It stimulates sympathetic tone, which results in high blood pressure, and ulcers and more anxiety. And it keeps feeding back on itself to make the stress even worse, which it's like a, I don't know, I guess a vicious cycle would be a good way to put it, because it's not, you usually feedback turns it back off again, but it feeds forward and it turns it up and up and up. Sometimes until somebody will actually start looking like they have Cushing syndrome, which is the tumor that makes you have too much cortisol and makes you have a real characteristic appearance. But it also pushes towards more cancer. It pushes towards more heart disease. It pushes towards chronic pain. Guess what?
Right. Yeah. And frankly, there really is an epidemic of chronic pain in the U.S. and really worldwide. The U.S. is, a lot of the statistics would reflect that, there are, is a very high percentage of adults, and up to even 20 or 25% of adults that report, daily chronic pain.
Chronic pain, probably,
depending on the study, at least 8% that report high impact chronic pain, which is where you can't function in the ways that you want to function.
Right.
Exactly. So we absolutely see those huge numbers, and it's hard to know the explanation for it. I do think that some of our diets and our behaviors play into it, but I think this is a really interesting other possibility, that it's, also the lifestyle and the stress that we have, right? That we carry, and that maybe exhaust some of our adrenal system.
Yeah. Well, and think about it. Chronic pain is more stress.
Oh, it is. It's like this vicious cycle,
It's a vicious cycle.
Chronic pain makes you stressed and depressed. Stress and depression makes you have chronic pain,
because you worry about, is it ever going to go away? How can I fix it? So it just gets worse and worse.
The evil twins, as we've called them before.
It's the evil twins.
The antagonistic evil twins.
Yeah. Well, and is it any wonder people are depressed? But if you look at the hormones, there is a physical reason for the depression as well.
Sure.
As just, I'm depressed because I'm in pain. No, you're depressed because your hormones are checked up.
Yes.
So yeah, it's really, it's kind of, it becomes this alternate resting state that's not normal anymore.
Well, and so tell me, to kind of get back to the positives that can happen, so you've had some turnarounds in your own health where you've been able to, with treatment, do better. And I imagine you have
absolutely
patient stories where you've really helped people improve their, lifestyle and performance. Tell me something about where you've made a difference, with this type of treatment paradigm with a patient or in your own life.
Well, as I kind of mentioned before, it started with me with getting my thyroid right.
Yeah.
Because once I had more energy to get through the day, and once my memory wasn't foggy, I mean, there's so many things that thyroid do to you. I was uncomfortable all the time. My memory was foggy, so it took me more effort to get through the day, and I had less energy to get it done. So for me, I think that was kind of the trigger, that and being done with residency, which was, residency is what it is. Started me towards, okay, you know what? I'm starting to feel like I have some autonomy. I'm starting to feel like I have agency over my life. I'm in a situation now where I'm not worried about money as much as I was before.
Right.
And I think gradually my adrenals started to recover on their own. But what I have learned more recently is that there are ways that you can supplement the nutrition that your adrenals need to help them work better. And here's the thing, a lot of the negative effects of the chronic stress happen when your adrenals basically run out of juice.
Okay.
So they run, so think about it like this. So they need vitamins and minerals, they need nutrients, and then they need enzymes. So if the enzymes are the tools in the factory, and the vitamins are the nuts and bolts in the factory, and the nutrients are the steel parts that your body uses, that the factory uses to make the cars or whatever, then if you will replace the tools and replace the nutrients, then the factory is going to be able to work better and go back to high capacity and start putting out convertibles and race cars and sedans and station wagons as well. And when I talk to patients about this, I say, your adrenal glands are like a car factory that got co-opted by the government to make tanks. And the government is putting in orders for tanks and more tanks and more tanks, and pretty soon you can't make convertibles anymore, and the next thing you can't make you can't even make sedans anymore because you're so busy making tanks. And eventually the tools start breaking and you can't even make tanks anymore. Tanks being cortisol.
Yes.
But that same factory makes sex hormones, and it makes something called aldosterone, which is what keeps your blood pressure up and keeps you from passing out on rounds, which is what I was doing. And it helps stimulate your thyroid, just because that's what it does. And so if you go in and you, first of all, you have the person do what they can with their diet to counteract the effects of the high insulin levels, and your body releases insulin in response to sugar or sweet tasting non-nutritive sweeteners, sugar, starchy carbs. And so if you will put them on a high protein, high fat diet, and try to get them off anything sweet, that helps a lot, because a lot of the bad effects of this cycle are caused by that very high insulin. So if you can get them to do that, they will feel, particularly the mood related issues will get a lot better. But then the next thing you can do is you can replace some of the nutrients that your adrenal gland needs. And there are glandulars, which are basically an animal product. It's basically the ground up adrenal glands of a cow, for example, or something like that. But there are particular adrenal glandulars, and they don't contain hormone. You're not taking hormones when you take them.
Okay.
What you're taking is the concentrated nutrients that your adrenal gland needs to function. So that's the first one. And it's better to get that as a neonatal bovine adrenal than it is to get it from a company that, uses old milk cows that are ready for the slaughterhouse. But that's the first one. So it's an adrenal glandular. And then the second one, so then the second one is pregnenolone. And what pregnenolone is, so all the hormones that are made by your adrenal gland start from cholesterol.
Yes.
Right. And they go through a series of steps. The enzyme changes it. And the first step in that factory, that's another reason why it's more like a factory. The first step in the assembly line is pregnenolone. And if you have no ACTH pushing through to stimulate your adrenals to make cortisol, if you skip that step to pregnenolone, then your adrenals can turn around and start making cortisol again. But they need pregnenolone also to make all the sex hormones. And sometimes what makes the patient feel really bad is the fact that all the pregnenolone that they have is going to make cortisol, and none of it is left over to make sex hormones. And so they get that extra, and then all of a sudden their ovaries start working again, and it's like, boom, I feel better. What? Oh, okay. So those are kind of two supplements that are really nice. In men, they can also take a little bit of DHEA, which is even further down that assembly line. Women don't want to do too much.
Androsterone, I think. Yeah.
Dihydroepiandrosterone, something like that. Yeah. DHEA. But women can take a little bit of that, but they shouldn't take a lot, because they will end up with too much testosterone and start growing hair on their chin and things like that. So not fabulous. But there are ways to measure to see if
how much
your adrenal steroids are really messed up or not. And the one that my mentor recommends is something called a 24-hour urine adrenal steroid protocol or profile, 24-hour urine adrenal steroid profile. And I think LabCorp has that, and insurance will actually cover it now if you have the right diagnosis codes going in there. But the adrenal glandulars and the pregnenolone are so safe that it's not ridiculously important to do that profile test.
Just have the patient try it and see if it.
Just have the patient try it and see. And there's a particular way that I recommend that it be done, because one thing you have to remember about cortisol is that it's a circadian rhythm kind of a release. So it's really, it starts up in the middle of the night, and by about 7, 8, 9 in the morning, it's at the highest it's going to be. And then it starts falling. And by dinner time, it's pretty low. And by 9 or so, it's about at the lowest it's going to get. And then while you're sleeping, it starts creeping back up again. And so you want to take that supplement. You want to take it in the morning, because you want to be having energy in the daytime. And then you want to take it right when you go to bed, so that your adrenals can make more cortisol overnight.
So maybe twice a day and one in the morning.
Yeah, but not just twice a day, morning and afternoon. You go to morning and then bedtime and then, and so there's a particular schedule. So I have people start, like the first week, they take 1 in the morning, and then 2 in the morning, and then 2 in the morning and 1 at night, and then 2 in the morning. And then if they feel like they're falling out in the middle of the day, they can take an extra one at lunchtime. But then it's 2, 1, and 2. But never take it at dinner time, because it'll keep you from falling asleep.
Yes.
And then once you've got that going, then you add the pregnenolone, which is that raw material that is made from cholesterol. And then things start snapping in, and it's like, oh, actually have more energy, actually feel like going around the block, But yeah, you have to combine that with mindset changes and the diet and, some kind of movement, and I think yoga is probably a good place to start, because it's not so much, you don't want to start with cardio. Let's put it that way.
It's not realistic for a lot of people, and a gentle yoga.
You want to start with something that's gentle, that includes stretching and that sort of thing. And then sleep, of course. And one great thing about the pregnenolone is that, if you've got patients who have been laying awake from 3 to 4 or whatever, and it's because they don't have estrogen anymore, then you give them the pregnenolone, and all of a sudden they find, oh, I can sleep through the night. This is so much better.
So that can be a big difference.
It's really, it's a double whammy. And the great thing about pregnenolone is that if your body doesn't need the excess, it doesn't just go and make more and more and more testosterone or whatever. It's just like, oh, we don't need this. It's extra. Okay, it can get peed out.
That's great.
It's not going to cause excess problems.
That's great.
Yeah.
Yeah, and so that's super interesting. Are a lot of the treatments that you're recommending, these sound like great supplement ideas. And then it sounds like there are sometimes prescription medications that might be warranted in these cases as well, or is that less common?
Well, sure. So the sex hormones
Mm-hmm.
always, always should be looked at under the supervision of a doctor.
Mm-hmm.
And they can be measured by
Yes.
blood tests or by saliva tests or urine tests to get those levels ideal, because there's some issues there. And then if the person needs thyroid testing, then I'm always recommending that they go to somebody who uses this integrative approach to thyroid, who knows what reverse T3 is and why it's important and how to measure to make sure that you're getting that to come down, because reverse T3 is a byproduct of thyroid hormone that actually blocks the active hormone from working. And so if you have a lot of that in your system, the rest of your numbers can look fine and you won't feel good.
Interesting. Yeah. And the reverse T3 is its own special test that has to be ordered separately?
Correct.
Okay.
Yeah.
Got it.
And there's still, that's one of those, waiting 20 years kind of thing. We're still in the waiting period there.
Yes.
So there's some insurance companies that have not wanted to pay for it, or things like that. So it can be a little bit annoying and irritating.
How do you approach that? I mean, I guess working with patients to try to push things through insurance, or, do you work with panels where patients, need to pay out of pocket? It's a real
right.
challenge.
So that particular panel, people will sometimes need to pay out of pocket. The test costs, if you get the cash price for that test in advance, like if you go to CPL or if you go to a doctor who has client bill, that reverse T3 test costs about $25, $26. It's not ridiculously expensive.
Yeah.
And when I order thyroid hormones, I order a 5-hormone panel. So I order the free T3, the free T4, the TSH. Those are pretty common.
Yes.
And then I order total T3 and I order reverse T3. And the reason I do that is because if you compare total and reverse T3, they're bound by the same hormone. So there's no complicated calculation that you have to do. You just directly compare them. And what you're looking for is you want about a 12-to-1 ratio of total T3 divided by reverse T3. And if you're lower than about 10, you're not going to feel good. And if you're higher than about 15, you're not going to feel good. You can look at the absolute number of reverse T3. And if it's high, it's really a universally terrible sign. But that ratio is really where it's at.
The ratio. Yeah.
Yeah. That ratio really gives you a lot of very powerful data that you can use to adjust somebody's thyroid medicine.
And then the thyroid medicine that's usually prescribed to adjust that is still usually the same thyroxine or Synthroid, I suppose.
No, it isn't, because here's the thing with that, is thyroxine is the precursor to the reverse T3. And when you have a lot of thyroxine, so the first thing that happens when people's thyroids start going south is that most doctors will put you on thyroxine. And if you're only taking your thyroxine once a day, the levels can get quite high for the first couple of hours after you take the medicine, and then it creeps down, so it's kind of low. And so it can look like everything is fine on your labs, but you've got this short period of time where the thyroxine is really high. And when it's high, your body thinks it needs to make reverse T3. Because reverse T3's natural function is to keep us from having too much thyroid in the course of like Graves' disease or something like that.
Okay.
To actually block the function of T3. And so if you don't know that that's happening, then you'll miss it.
Mm-hmm.
And so that's why mostly what I supplement with is a mix of thyroxine and the active T3, which cannot be directly turned into reverse T3.
Okay.
You can't just give T3
Mm-hmm.
because there are some non-genomic and non-direct effects of thyroxine that we don't really understand super well.
Mm-hmm.
But what we do know is that when people's numbers get too low, they feel terrible and they respond terrible. So you have to keep that free T4 number above about 0.7.
Mm-hmm.
But you don't want it up above, you don't want it high.
Mm-hmm.
You want it to be, 1.0 is a pretty good ballpark. 0.7 to 1. But then the free T3, you want that to be around 3.5, 3.8.
Mm-hmm.
Even though the normal as anything above 2.2 is normal. And I'm like, it may be normal, but it ain't good.
Yeah. Or not like physiologic for the individual.
No. Yeah. I mean, we could talk all day about how I think those reference ranges were done improperly.
Yeah. I think it's easy to rely on them because they're there, but yeah, I think your point is well taken that reference ranges are,
what I tell people is there's the reference range and then there's the ideal range. That's kind of how I put it.
Yeah. And really for me, that kind of starts to tread into that like idea around like functional medicine, which is like a popular buzzword around like maybe optimizing, certain values for patients, whether with nutritional strategies or supplements or medications in this case also.
Exactly. Yeah. And the two things that I mentioned are both supplements. They're both available over the counter.
Yes.
So, but yeah, the thyroid, you need a doctor to help you manage that.
Sure.
That's not something you can just go and do on your own.
Yeah. Well, I think this is so important. And, I have so many patients that could benefit from feeling better, from exploring if their thyroid or adrenal gland is at play. It's really not something that's been part of my practice per se, but I'm excited to know that that you're a resource and that you're treating patients. Tell us more about where people could find you. If there were patients, particularly, I believe right now your practice is in Texas. Tell us more about how patients can find you and connect. I think I've got your website here that I can make sure to put in.
Right. So my my practice is in North Texas, and in Texas you do have to see somebody in person to establish before you can go on and use virtual visits. I do have a website, and it is my name, DanaGibbsMD.com. And I also have all kinds of socials. I have a Facebook page that's Consultants in Metabolism, and I have a YouTube channel, and all of it is under my name, Dana Gibbs MD, so that you can find it. And I do lives every week on Tuesdays at 6:30 Central.
Awesome.
About various aspects of hormones and thyroid and stress and that sort of thing. And I think we are copying all that stuff to YouTube.
Awesome.
So it should be there.
Well, you heard it here, folks. If you have questions for Dr. Gibbs, she just told you a great way to engage with her and ask some questions, which would be coming into her lives on Facebook on, you said Tuesdays?
Tuesdays at 6:30.
6:30 Eastern?
Yep.
I mean, Central.
6:30 Central, so 7:30
Eastern.
7:30 Eastern,
Come and engage. Yeah. Awesome. Well, I think I'm going to wrap us up, I think, because I love the conversation, but I want to be respectful of everybody's time and would be glad to have you back and talk more about the effects of stress on pain and how we can manage it better, how we can feel better. Always so important. So yeah, thank you, Dana Gibbs, Consultants in Metabolism, for being here. And this is Sarah Merritt with Lifestream Health Center in Bowie, Maryland, signing off. If you're in Central Maryland or Washington, D.C., come see us. You can call us to schedule at 301-860-0305. Thank you.
Awesome.